Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Welcome to our second session webinar of the day. It gives me a great honor to introduce the Healthy People 2030 Initiative, a United States initiative. This is a webinar series conducted in collaboration with the United States Department of Health and Human Services, Division of Office of Disease Prevention and Health Promotion. The goal of this webinar series that we will be hosting on the Global Summits page is to make people aware of all of the information that's out there to create a better and more environment that allows us to be healthier in the next decade to come. Before we start with our webinar, just general updates and housekeeping information that I would like to share with you. As you know, the big event is coming up, the Doctors World Gala. We currently have over 300 key opinion leaders that have already confirmed and reserved to be there. It is going to be likely one of the most impactful events of 2023 pertaining doctors in dentistry, optometry, pharmacy, chiropractic, medicine, and medical philosophy. Highly encourage you guys to join us. If you want to know more information about who, how, and when, we got about 1,000 doctors that are going to be there, 500 on the Congress side. How to register for the World Gala, how to register for the Congress operations are easily obtainable by following the hashtag Doctor2Doctor, basically Doctor, T-O, Doctor. And you will have all the registration links, but I will also go ahead and share some QR codes that you can scan if you want to go to a certain area. There's going to be a lot of activity there. You're going to have all sorts of different events, such as the red carpet event, the reception, the gala dinner, the awards ceremony, the concert. A lot of exciting stuff that's going on at night times when we are not in an academic environment in terms of the Congress, where it's going to be solely focused on the simplicity of excellence in dentistry and medicine. We invite you guys all to come out and join us. Here are the QR codes, and I will also list the actual URLs if you don't get a chance to grab these real quick with a cell phone. But otherwise, enjoy the first session today, and we will continue plugging in. This particular session pertains also to access for children and adolescents. And with that said, Mr. Gupta, please play and start the webinar session. Thank you.
Okay, we're recording. Katahdin Valley Health.
All right. Good morning, good afternoon, everyone. Thank you for joining today's webinar. This is the first in our Healthy People 2030 Oral Health Objective Promotion Series. My name is Dr. Tim Ricks, and I currently serve as the Chief Dental Officer of the U.S. Public Health Service. And in fact, today is my last official day in that role. And I also serve as the Indian Health Service representative to the Federal Healthy People 2030 Oral Health Work Group. Before we get started, let me remind everyone that this session is being recorded. And if you would, please mute your audio. And at the top right of your screen, you'll see View. And we ask that you click on
understand about how
month, every other month, we'll hold a webinar that features the overview of a specific Healthy People 2030 oral health objective, and we'll attempt to tie those objectives into existing national health observances. Each of these webinars will feature a federal agency moderating questions and 2 independent private organizations discussing the particular objective. So today we'll begin this series with a session entitled Improving Access to Achieve Oral Health Equity. Former Surgeon General C. Everett Koop once said that you cannot be healthy without good oral health. We know this to be true as there are many connections between oral health and overall our systemic health. And it all begins with access to affordable, geographically available, culturally competent, quality, and patient-centered oral health care. Today's webinar is co-sponsored by the Federal Oral Health Work Group, the American Dental Association, and the Medicaid Medicare CHIP Services Dental Association. As I mentioned, this webinar is being recorded, and when the recording link is made available, we hope that you'll share this broadly. Next slide, please. As we begin, here's our disclosure statement. As the statement says, we will cite any non-Healthy People 2030 references throughout the presentation. Next slide. Here are the learning objectives for today's webinar. Upon completion of the webinar, each of you should be able to, number 1, define and describe Healthy People 2030 Oral Health Objective 0H-8. Number 2, describe the disparities that exist in access to oral health services based on geography, race, ethnicity, and income level. And number 3, implement at least 3 activities in your community to specifically address Oral Health Objective OH-8. Next slide. Here's a presentation overview of today. I'll start with giving an overview of the objective, and then I'll be followed by Dr. Jane Grover from the American Dental Association, who will talk about why access to dental care is important for all Americans. She'll be followed by Ms. Mary Foley from the Medicaid Medicare CHIP Services Dental Association, who will talk about how access is inherently related to equity. And then finally, we'll close out with Dr. Gina Thornton Evans, who is chair of the Federal Healthy People Oral Health Work Group, who will moderate a question and answer session and announce the next Healthy People webinar. Next slide, please. So now let me introduce each of these speakers in our distinguished panel. First of all, as I mentioned, I am the Chief Dental Officer of the U.S. Public Health Service, at least until the end of today, as I retire after 35 years of government service, including 23 in the U.S. Public Health Service. I also serve in various roles within the Indian Health Service Division of Oral Health, including Continuing Education Director, Oral Health Promotion Disease Prevention Coordinator, and Oral Health Surveillance Coordinator. Dr. Jane Grover is the Director of the Council on Advocacy for Access and Prevention with the American Dental Association, previously serving as a dental director and AEGD residency director for the Center of Family Health in Jackson, Michigan. She has also owned a private practice, served as ADA vice president, and had an adjunct faculty position at the University of Michigan School of Dentistry in Ann Arbor. Ms. Mary Foley is the Executive Director of the Medicaid Medicare CHIP Services Dental Association, or MSDA. Her understanding of legislative and regulatory policy has helped to advance quality and value-based programming across state dental programs. As an epidemiologist, she has helped to advance data-driven policies aimed at improving oral health care, and lowering costs associated with oral health care for Medicaid beneficiaries. Finally, Dr. Gina Thornton Evans serves as a senior dental officer with the CDC Division of Oral Health, where she oversees the management of the National Health and Nutrition Examination Survey, NHANES oral health component, focusing on the strategies to improve and enhance surveillance measures for oral health. She also serves as the director of CDC's Dillon Public Health Residency Program. And as I mentioned before, she's the federal lead on the Healthy People 2030 federal work group. And she's also oversees efforts related to highlighting the leading health indicator for oral health. Next slide, please. So let's begin with an overview of Oral Health Objective 8. Next slide. The Healthy People 2030 Oral Health Objective 8 reads as follows: increase the proportion of children, adolescents, and adults who use the oral health system. This objective is one of 23 leading health indicators for Healthy People 2030. Leading health indicators, or LHIs, are a small subset of high priority Healthy People 2030 objectives selected to drive action toward improving health and well-being for all Americans. So it's very significant that oral health is among the leading health indicators. Most of these LHIs address important factors that impact major causes of death and disease in the U.S., and they help organizations, communities, and states across the nation focus their resources and efforts to improve the health and well-being of all people. Using a data source called the Medical Expenditure Panel Survey, or MEPS, our baseline for Healthy People 2030 is 43.3%, meaning that according to the data source, 43.3% of Americans accessed dental care at the beginning of this decade. The target is 45.0%, meaning that by 2030, by the end of the decade, we hope that we'll have 45% of Americans who have accessed dental care in the past year. Next slide, please. And as you can see, we've actually achieved that mark before. On the left is a table with data from Healthy People, and on the right is a table from the Medical Expenditure Panel Survey, and they both show the same thing, a trend of access to dental care in America. So as you can see, we have never achieved an access rate above 45%, and we did achieve that rate back in 2003. In 2020, Healthy People had the same objective, and we had hoped that we would get to almost half of all Americans getting to the dentist in the past year, 49%, but we only reached 43.3%. So our goal in 2030 is really to get back at least to where we were back in 2003 at that 45.0%. Next slide, please. So why is access important? Access to care drives the inequities that we see in our country, a point which our subsequent speakers will drive home in more detail. This table is a summary of a report published by the Centers for Disease Control and Prevention in 2019 that shows disparities by race, ethnicity, and income level across the lifespan in a variety of dental conditions, including caries experience or prevalence, untreated decay, and total tooth loss. And as you can see from this table, Black, non-Hispanic Americans, and Mexican Americans, as well as those living at or below 200% of the federal poverty level, which is close to $25,000 for a family of four, suffer disproportionately from dental disease. And I've put that in red fonts to make it easier to read. Next slide, please. There is a direct correlation between these disparities and access to affordable, geographically available, culturally competent, quality, and patient-centered oral health care. This graph that you see now, which is courtesy of the American Dental Association's Health Policy Institute, tracks access to dental care for children over two different time periods, 2005 and 6 and 2017-18. The burgundy color is U.S. white children. The teal color are U.S. Asian children. Green is U.S. Hispanic children, and the orange are U.S. non-Hispanic Black children. And as you can see, white non-Hispanic children have the highest access rate at 55.5%, as indicated by that dark burgundy bar, while Black non-Hispanic children have the lowest access rate at 42.6%, as indicated by that dark orange bar. The good news is that access does continue to improve for among whites, Asians, Hispanics, and Blacks. Next slide, please. Now, using the same legend with U.S. whites being the burgundy color, U.S. Asians being the teal, U.S. Hispanics being the green, and U.S. Blacks being the orange. This graph, which is also courtesy of the ADA's Health Policy Institute, looks at the percentage of adults with a dental visit in the past year. Again, if you look at the bars, white non-Hispanic adults have the highest access to care at 47.8%, as indicated by the burgundy bar, while Hispanic adults have the lowest at 27.8%, as indicated by the dark green bar. The gap between the highest and the lowest is 20%, which is much higher than that disparity that we've seen in children, which was 13 percentage points. Next slide, please. We also see geographic differences in access to dental care. This map, which is courtesy of the Health Resources and Services Administration, or HRSA, captures health professional shortage areas in dentistry. And they capture health professional shortage areas in primary care, mental health, and in oral health. But the various shades of gray that you see here, and most of Nebraska should also be shaded, they just use a different metric. But these show that the vast majority of land in the U.S. Is designated as a health professional shortage area. And most of these are in rural America. In fact, HRSA says that there are 61 million people living in over 6,500 dental health professional shortage areas, and would take almost 11,000 practitioners to move to these areas to remove that HPSA designation. Next slide, please. Finally, also in terms of geography, we know that there's a difference in density of dentists from state to state, and of course this impacts access to care. The Northeast Corridor, led by New Jersey, has the largest number of dentists per 100,000 at 81.52, which is over 30% higher than the national average of 60.89 dentists per 100,000 people. The Southeast, which is led by Low in Arkansas at 40.93 dentists per 100,000, has the lowest density of dentists. Next slide, please. So at this time, I will turn it over to my esteemed colleague, Dr. Jane Grover, to continue with the webinar. Thank you.
Thank you very much, Dr. Rick.
Stop.
Thank you very much. My name is Dr. Jane Grover. I'm the Senior Director of the Council on Advocacy for Access and Prevention for the American Dental Association. And thank you for joining us. My focus for this webinar is why access to care is important for all Americans. And there are multiple reasons for that. And you're more than aware that there are multiple reasons why access to care is important. This slide is special to me because the young lady, child that is at the far left side of this was a young lady that was brought up in a rural state and also was an enthusiastic patient of a dentist colleague of mine. She was a publicly insured child. And the next photo over shows this young lady ready to graduate from dental school and begin her pediatric dental residency program. So why is access to care important? Because it inspires others within a generation to step forward and make access to oral health care an important part of what they choose to do professionally. We've got two other photos on this opening slide, and those show the community dental health coordinators that are very actively helping connect patients to care. We'll talk a little bit more about that going on, because this is so important about increasing the proportion of children, adolescents, and adults who use the oral healthcare system. Next slide, please. So if we talk about access and we talk about barriers, and this is a particular focus of the American Dental Association, last year our House of Delegates passed a health equity resolution, which has become policy for the American Dental Association. And we have been working to improve access along multiple planes, but also addressing barriers to care, obstacles that prevent access. Some are extremely visible and some are less than visible. But the important part of this is addressing the barriers, which can be topics such as health literacy, but also that connectivity between patients and sites of care that are available but are underutilized. And having spent 12 years in a community health center, as many of you already know, that there are sites of care that we need to do a better job of connecting patients to. Next slide, please. Access is critical for multiple reasons, of course. It's not only part of an economic engine with the small business community, with any size of company. Oral health is integral to overall health, and you can't have an efficient company without a workforce that is ready to work. Activities of daily living, effective school performance. Many of you already know the statistics about how many million hours are lost from school. Employability is extremely important because how patients perceive their smile, how they perceive their ability to be hired for a job is very impactful. So we know that oral health impacts all of critical life functions, from education to employability to overall health. So how can access be expanded? Next slide, please. Addressing barriers to care. And this is a particularly important slide and one that we are working very diligently to promote the awareness among all of our members, but also enabling and empowering our members to recognize these and engage with stakeholders in their community. The dental office is not just a silo. It can be a hub and a hub of connectivity. So it is only part of the equation of how to engage and promote and expand oral health access in a community by looking at the positive health behaviors, by looking at those upstream determinants, which have not been as widely promoted in the dental world as they have the medical world. Even here in the city of Chicago, navigators and case managers are integral to elementary schools. The opportunity with our community dental health coordinator program, which is a dental version of a community health worker, is extremely important, and we are seeing great success with that program, particularly in hospital and interdisciplinary settings. Next slide, please. So we'll talk a little bit more about addressing the barriers. Having insurance, having coverage doesn't necessarily mean that people have access, but there are certainly some very robust improvements that are going on, reforms that are going on within the insurance industry. There's also the tremendous expansion of oral health programs within the community health center setting, where I spent many years. And this weekend, in fact, most recently, I attended the Community Health Institute of the National Association of Community Health Centers. And I heard from multiple CEOs of community health centers that oral health remains and has escalated in visibility as a priority because of the recognition of the case managers and having co-located medical and dental settings. This is an extremely important part of a team approach to addressing barriers to care. Next slide, please. Overall dental spending. This is from our Health Policy Institute, and this is readily available through ada.org. But if we look at national dental expenditures by source of financing, we see that, of course, COVID played a role. Dental spending did decrease over the 2019-2020 period of time. We see that the government programs had a slight decrease, but tremendous increase in the out-of-pocket other category, which is the gold at the bottom. That is believed to be increased by 481% due to the COVID-19 Paycheck Protection Program and the Provider Relief Fund. The bottom line is that spending can be improved, and in particular, as we come out of this unfortunate pandemic, we would look forward to seeing that increase. Next slide, please. Oral health is about health equity. This slide is from Dr. Natalia Chalmers, Chief Dental Officer of CMS. And as we see, the dental caries in children and adolescents, according to poverty level, as Dr. Ricks has already pointed out, the disparities continue and are evident in the caries experience. In particular, white, not Hispanic, compared to the adolescents. That proportion of children can be improved, and we have seen some improvements in children that are accessing care, publicly insured, privately insured. That has improved over the past few years, but there is still a long way to go. Next slide, please. Disparities in tooth decay by race, ethnicity, and income. Some improvements have been made, but again, we still have our work cut out for us to move the needle further ahead and reduce disparities among Mexican Americans, non-Hispanic whites, non-Hispanic blacks. There's been some improvement according to the NIDCR report, which was released in February, and we'll get into that a little bit later in this presentation. Family income, you can see, has a tremendous impact on active and untreated tooth decay. Next slide, please. Frequency of oral health tasks. Who can help us improve access to care? Is it the dental world alone? And the answer, of course, is not. There is multiple stakeholder groups that are moving oral health forward, and our good friends at the American Academy of Pediatrics are just one example. The AAP gave us a wonderful presentation in July at our council meeting, and they are all in on providing oral health preventive services, but also tracking and improving oral health tasks during health supervision for children, particularly the well baby visits. We see this improvement not only with pediatricians, but with also in the community health centers where we've got co-located medical and dental professionals. You can see that the pediatricians have really improved some of these key tasks, oral health tasks, and this solidifies what the dental students of today are experiencing, and that is interdisciplinary care, the role of collaboration with other medical stakeholders in improving the opportunity and improving access of oral health for children. Next slide, please. Another example of the American Academy of Pediatrics adopting those states that adopted a Medicaid policy for reimbursement of fluoride varnish by non-dental providers. Is there additional opportunities to improve oral health and the referral process between non-dental providers such as pediatricians and dentists? The warm handoff, the dental home, the opportunity now that many health centers are capitalizing upon, and that is to have a dental professional within a medical-only location so that there is enhanced opportunity to provide interdisciplinary and sound, efficient referral processes between the medical and dental worlds. This is only one example. Next slide, please. Thank you. Another question that's been asked, and of course, many studies have been looking at this topic, parents are the key to coverage and access. When a parent has a dental visit, you can see it is much more likely that children are engaged with the oral health system. And it just goes to prove that if you have family-centric care, you are really improving access to care, improving utilization of the oral health system for adults and for children. This has been an important part of advocacy for the American Dental Association, and that is improving dental Medicaid benefits for adults. And we have seen some significant improvements and reforms in at least 15 states so far, and more on that topic yet to come. Next slide, please. So the good news since 2000, when the first U.S. Surgeon General Oral Health Report came out, as we look at that report released in February from NIDCR, obviously there are challenges remaining, but there are some key takeaways that have proven to be some good news. 50% reduction in untreated decay among preschool children, and the sealant placement rate improving among teens living in poverty. Edentulation has decreased. Number of pediatric dental residencies has doubled in the past 20 years. This is so welcome, in fact, regarding the opportunities to provide care for very young children and to reinforce the notion, and ADA has policy on this, that the age 1 dental visit is critical. And knowledge of that should not just rely within the dental world only. Everyone should know, everyone who touches a child's life, either educationally or in a stakeholder group, should be aware of that age 1 dental visit. And the recent expansion of adult dental Medicaid in several states is another key part of this. Interdisciplinary care has expanded. This tends to be a foundational piece now for dental students, and they are graduating expecting to have a conversation and an ongoing professional relationship with multiple stakeholders. Next slide, please. Again, continuing preventive service delivery outside of the dental office.
Irina.
A big trend has been, again, it isn't just what happens in the dental office, what happens in the dental operatory. The opportunity here is oral health services, preventive services. The recognition of the need of a dental home has gone outside of the dental operatory, and we are excited to see that continue to unfold. Oral health integration within primary care. Again, echoing what I heard as recently as this weekend from the National Association of Community Health Centers, very involved in moving this forward. Other good news, increased diversity of the oral health workforce. The dental students of today are certainly going to move forward with a strong sense of expanding access to care because they know firsthand that the social determinants of care are now suspected to influence care more than the care itself. And of course, we're all dealing with vaping and e-cigarette use. That's been an unfortunate trend in the last few years. Next slide, please. The dental workforce, the mix, male versus female, and various ethnic mixes. The dental workforce is changing. The dental workforce doesn't look like it did 10 or 15 years ago, and the opportunities here are immense because not only do these graduates more closely resemble the populations of interest, but they have a strong sense of social networking and a strong sense of social obligation for their professional calling. And this is another slide from our Health Policy Institute. Happy to send you that entire slide deck if you'd like. Next slide, please. Again, still a long way to go. Improvements are made, but with 70 accredited dental schools right now, with a total enrollment of over 26,000, we look forward to seeing what these dental students of today will do to move the landscape and to improve and embrace the Healthy People 2030 objectives. Next slide, please. Thank you so much. I'd like to introduce Mary Foley, our next speaker. Thank you, Mary.
Thanks, Dr. Grover. I appreciate it very much. Can you folks see me? Want to make sure. everything's going all right here. We do have a little bit of technical difficulty. Just want to report that. So if you know someone that's having trouble getting in, you can have them try again. Anyway, thank you for being here. I appreciate it. And it's a pleasure to be working with my colleagues, my federal colleagues and national colleagues on this webinar today. So many of you may be familiar with the Crest toothpaste commercial that came out in the 1950s that set the standard, believe it or not, for preventive dental care. See your dentist twice a year. Any of you remember that? There was no science behind the statement, but it stuck. And for nearly 75 years, we in dentistry have followed this and have made it the gold standard. Seeing your dentist twice a year for preventive care. Now, for those of you that are clinicians and who've worked in practice, you know this really doesn't work. It doesn't work for everyone. So how could this be the gold standard? The truth is, there is no singular gold standard if we're going to have a conversation about equity. If we're going to address the oral health disparities that exist across America, we need to understand where they lie. We need to understand who is at the greatest risk and make the systems change to deliver patient-centered care, risk-based healthcare that ensures equitable access in healthcare and oral health care to all those that we want to care for. Now, this diagram, many of you have seen it before. It's the one size versus all versus the patient-centered care. That's how I choose to look at it. It's equality versus equity. For years and years, our system, our oral healthcare system, and healthcare in general, right, has been designed and developed and administered in a way that provides an equal, right, type of benefit for everyone that's enrolled in the benefit. But what we've come to understand better now is that not everybody fits into that perfect little package, and that we actually do need to pay attention to what these individual needs of patients are. And when we do, we can better address equity and better, end up with a more equitable healthcare system, equitable oral healthcare system, and equitable oral health. So how can people receive dental care that they need when the oral healthcare delivery system does not have the inherent capacity, as it stands right now, to identify need, monitor it, and address it? And I'm speaking about at the systems level. So many of you are clinicians, you may be saying, what's she talking about? I'm talking about at the program level, at the health plan level, at the commercial level, at the Medicaid level. So this is where we're at right now. If you look at the round circle in the center, it's really the traditional model of dental care or of healthcare. It's where the member manages his or her own healthcare. Now, out in the world, we have government insurances like Medicaid and Medicare, right? And we have employer-based health insurances, and both of which have benefits or have a plan and pay for those services. And the health plan manages or administers, or the state administers the benefit and pays for those services. In some cases, the member also pays, there's a copay, but if we talk about Medicaid, for at least for children, that copay doesn't exist. But what does happen is, in this traditional model, members have to engage their own PCP, primary care provider. They have to find their own OBGYN and go to their own services, find their own dentist, their own eye doctors, et cetera, right? And once they receive those services, the government or the employer pays for those services as they have been utilized. In this model, there is no vehicle for integration, for communication or coordination of healthcare among providers, because the arrows, as you see, goes from the member to the provider, with no arrows in between providers, right? But also in this model, there's a gap when it comes to measuring oral health status and oral health outcomes. And again, this is a gross depiction of what this model kind of looks like. The problem is here in the United States, we have 154 million Americans who receive and rely on government services for their health coverage. In Medicaid, we have over 87 million. In Medicare, over 64 million. And in the marketplace, there's 14.5 million Americans that receive health coverage from the government marketplace. This is a lot of Americans. And of course, also, in the last 2 years, since February 2020, when the pandemic hit, through May of 2022, we've had this huge upsurge in Medicaid eligibility by 28%. Now let's think about everything that you know about Medicaid, all the frustrations and barriers you have with it, and imagine if there was a 28% increase, right, in the number of enrollees in these programs that have to be managed, that have to have services available to them, and have to have them paid for by government programs. So clearly we have a changing dynamic that's going on here, and we have a system that isn't quite up to where it needs to be. Now I love this slide because this slide really shows an inverse proportion to Medicaid enrollment and the Medicaid expenditures. If you look at the bottom row and you see the pale blue rectangle on the left, it says basically that 38.9% of Medicaid enrollees are children between the ages of 0 and 20. Yet, if you look just above it and you look at Medicaid expenditures, this 39% of enrollees only use 16.1% of all of the dollars in the Medicaid budget. And if you go to the far right end and you look at the aged 65 and older and people with disabilities, the dark green and the blue, the deep blue, you can see that they make up the smallest number, if you will, of Medicaid enrollees, yet they use the largest amounts of dollars to support, of the Medicaid budget. So there lies a challenge, right? This inverse proportional enrollment to expenditures. And so we need to be aware of this when we're thinking about how do we improve, how are we going to act on and try to improve this Healthy People 2030 objective in our delivery system when we have these inherent issues that currently exist. So we need to be aware of that, right? Okay. This slide came from CMS actually just this week, and it basically looks at the emergency department use. And what I like about this slide is that it helps to demonstrate exactly the access problem that we have in the US. If we didn't have an access problem, people would not be using the emergency department when they have non-traumatic dental problems. They would be going to their community local dental office, all right? If you also look at this map, you can see how some states, right, can have a lot more people that are using the emergency department than other states. So it isn't just a problem where that is the same across the United States. It varies by state, and it has a lot to do with the availability of dental benefits. Okay, so if you have a more robust adult dental benefit in your state, you're less likely to have people using the emergency department. And this is a wonderful slide that depicts that. Now, here we also have, the percentage of Medicaid eligibles that are actually receiving any dental service. And this is children, part of the EPSDT program, again, across the US. And what this shows is the variability, right, in the dental benefit, in the use of the dental benefit by Medicaid enrollees, by Medicaid children across the United States. So in some states, you have very few that are actually using it. And in other states, you have a much more robust use of the dental benefit, which speaks to, one, do they even know they have the dental benefit? Two, do they understand the importance of and the value of the dental benefit? And three, even if that's possible, what other barriers could be in place that's inhibiting them from actually using that dental benefit? This is a slide that basically demonstrates what happened, when COVID hit. Okay, so it looks at the rate of dental services use by children just before the pandemic, the top line, and then the bottom line following it. So you can see this big dip, okay, in services. But then as we get to now, we're still 18% fewer services below what we were pre-pandemic. So again, if this is what we're seeing out across the United States, what we understand from this is that there is a huge pent-up demand out there. There is a lot of kids that are not getting services, and the extent of disease, what happens, it only can get worse there. So the untreated disease levels are going to increase. This was Dr. Ricks's slide, and I bring it back to the presentation this afternoon because I want to call your attention to the lower portion that looks at income and the variability between individuals or families that are under the 200% of the federal poverty level versus those that are over 200%, equal to or over 200% of the poverty level. And you can see the red, the individuals that are less than 200% of the poverty level, almost twice as many in almost every category, right? So you can see where these disparities lie in both in caries prevalence, in untreated disease, across all these different age categories. So again, I call that to you because if this slide is depicting oral health status or disease status, okay, now we're going to get into some data about utilization by these low income groups. Okay, so that's why that's there. So in federal fiscal year 2019, there were 39 million children enrolled in the EPSDT program. For those of you that don't know, the EPSDT program is the Medicaid program that serves children, low-income children, between the ages of 0 and 20. When they turn 21, they age out of this program, and under Medicaid law, they become an adult. Under Medicaid law, the EPSDT program is, dental services are mandated, okay? So the availability of a dental benefit is there, albeit different, slightly different across the states, but it is required, it is an entitlement for children under this program. This slide just looks at the enrollment by age category. So you can see how many children under the age of 1, how many, almost 10 million children between the ages of 10 and 14. And if we go back to one of Dr. Ricks's slides, which I'm not going to go back to at this point, we saw that that the onset of dental caries and the prevalence of untreated dental disease among that youth group, that 10 to 14 and 15 to 18, is really, really high. So let's look at these, keep these denominators, these are the denominators, keep these in your mind, the 9.7 million, the 6.7 million, the 7.5, keep those in the back of your mind as we go to the next slide, okay? So among these, okay, this is any dental service. How many of them, or what percentage of them, actually had any dental care service during the same federal fiscal year, okay? And so basically what we see for any dental service, if we look at this 10 to 14 group, that 59% of them had any dental service. Now, this data metric does not tell us what kind of service it was. It's just, and they got into a dental office. And so it is an important metric because one would presume if they at least got into a dental office, then they could potentially be triaged to, begin to receive that routine dental care. And it could also be a preventive dental service. But again, this is just a very broad metric right here, all right? When we look at this and we consider, and this is the important part of this conversation, when we consider that 59% received that dental benefit, what we don't know by just looking at this data, what we don't know is who they are. We know that they're between the ages of 10 and 14, but we don't know anything else about them. Now, I can tell you that some state Medicaid programs have in the past collected race, ethnicity, and some other data, but it has never been used okay, to improve program administration, to improve use of services, if you will. So, so it's time now to take the same data that we've been looking at and to mine it a little bit more, to get a better understanding, not only of who the 59% are that use the benefit, but how about the other 41% that did not use the benefit? Who are they? Where are they? What are their barriers? This is where the delivery system and folks on this call can begin to think about this a little bit differently. Okay. So this slide is looking at any preventive service. So the other was any dental service. This is any preventive dental service. And clearly you can see this is a subset of the former slide. And I'm still going to just zero in on the 10 to 14 age group, just to kind of call your attention to what the whole slide really means. Among those millions of children between the ages of 10 and 14, 56% of them had at least one preventive dental service in the same year, federal fiscal year. Okay, so again, we want to think about who is that 56% that received that benefit, but who are the others that didn't, and how can we reach them? For dental sealant utilization, okay, so we know that 85% of dental disease occurs on the occlusal surface of molars, right, of permanent molars. And we also know that dental sealants are highly effective at preventing dental disease. So if we have dental sealants on permanent molars, if not primary molars, if we have it on permanent molars, at least on permanent molars, we know that we can really, really make a mark at preventing disease, from initially preventing it and certainly preventing it from advancing. When we look at the data from the Medicaid EPSDT program, we see that in federal fiscal year 2019, only 17% of children between the ages of 6 and 9 received any dental service, any dental sealant service, okay? And that older children between the ages of 10 and 14, for the 12-year molar, only 14% of those received a dental sealant, at least one dental sealant on a permanent molar tooth. So clearly we have our work to do, right? And again, who are the 14% that got it? Who are the 17% of 6 to 9-year-olds who received a dental sealant? Where are they? Where are they located? But the better question is, who are they? Why were they able to get it? And who are the others, right? The others that didn't get it. And those are the important questions we absolutely need to start asking. This looks at dental treatment. Now, again, going back to Dr. Rix's slide, we looked at untreated dental disease, right? They were pretty high among that 10 to 14 age group. And we see here that only 28% of Medicaid beneficiaries between the ages of 10 and 14 actually received at least one dental treatment service during that federal fiscal year. And this was, I should call this to your attention again now, this was before COVID, right? This was before COVID. So that's why these numbers really are important. We can't look at this and say, well, you know, COVID was going on. This was prior to COVID, okay? And then just a couple more slides here to talk about. Again, this just looks at Medicaid enrollment to dental providers. So if we're talking about equity and we're talking about accessing care and the relationship between receiving dental care, accessing dental care, achieving oral health, achieving an equitable state among Americans, among children, among Medicaid beneficiaries, I want to call to your attention that just because a Medicaid beneficiary or a Medicaid enrollee is low income and in the Medicaid program, that does not necessarily make them high risk, okay? And so again, all the more reason to be mining that data and determining, you know, who are the people getting care and who are the people in this group that are not getting care. But if we look at the relationship between enrollees or beneficiaries to the number of dentists in the country that participate in the Medicaid program, you can see it's a lot. It's pretty high. And one dentist would have a hard time seeing, 945 Medicaid beneficiaries if they were all spread out across the network. So clearly, more has to be done to really study the dental workforce, which is what we call it when we talk about public health programs. If we are looking at this from the delivery system, we call it the dental network. So they're both the same providers that are out there providing, but if we're talking about the workforce or the network, depending upon where we sit, we use different language. For me, I'm in the Medicaid world at this point, and so I look at how can the Medicaid programs or their vendors, the managed care organizations, okay, how can we do more to incentivize more of the dentists in this country to participate in the Medicaid program so that we can make a mark on this particular metric here. So we've looked at a lot of data, and we've looked at it the same way for many, many, many years. And you know the saying, if you keep doing things the same old way, you're going to get the same old results. So we're going to really take a deeper dive. And the way to do that is to really look at, the data, but to dive into it and conduct a gap analysis. If we think about this particular Healthy People 2030 Oral Health Objective, 08, and we look at access, where do we want to be? There's a specific target, 45%, I think it said, right? So how are we going to get there? Where are we today? And how are we going to get there? We really need to lay out that plan, and we need to monitor that data. And then we need to, as I said, mine that data a little bit more carefully. So my recommendation is that we really do that the delivery systems, because the public health systems are already looking at prevalence of disease and prevalence, right? Dr. Ricks showed beautiful slides on prevalence. The dental delivery systems don't use that data. I hate to say it, but they don't. And so the delivery systems need to use every one of those metrics that we were just looking at for the country. They need to use those same measures and those same metrics by plan level, by state level, by Medicaid program level, so that we have a better handle, and so that dental program administrators have a better handle of what is the oral health status of the Medicaid members that are enrolled in that state or in that plan. We need to start using dental diagnostic codes and align more closely with our medical colleagues. If medicine can actually use, and it doesn't have to be ICD-10, I'm just going to use that as an example, but the diagnostic coding that we are not using, that we should be using, needs to be able to be understood by medicine, and the codes that medicine is using needs to be understood by dental. And this needs to take place at a systems level. So Dr. Grover talked about all this wonderful stuff that's happening in dental education at the clinical level. If we want to see this operationalized and really, and really the vision that we have for integration to be realized, it has to happen at the systems level. It has to happen through the coding processes that we have in place. We just need to up the ante on that and start using those codings. We need to document in dentistry medical necessity using those codes. We need to be able to do that. And most importantly, it isn't enough just to have these codes and have these numbers. What do they mean? We need to be able to measure them and apply what we've come to understand about the health outcomes. So that is something that we need to do at one level. But then when we're looking at who's actually using services, remember when we were looking at those slides of who's the 59% that got in and used those preventive services, but then who's the other 41% that didn't? We need to be tracking that very, very carefully and seeing, who's using, who isn't. And then we need to be measuring, even more importantly, their health outcomes following the use of those services. Okay, but in order to do that in an equitable manner, we need to mine the data. Now, we've seen today that the data has been mined at a national level, but we need to do it at the plan level, at the state level, and each of the states need to start being able to do that. And so these measures down here are additional measures that can actually be used, okay, by the state Medicaid programs, by their managed care organizations, or by any other plan, so that we really have a better handle on the oral health status through the delivery system, Now, that isn't enough either. So we've been talking for 20 years about the social determinants of health. And unfortunately, we in dentistry have had a real challenge with trying to figure out how to operationalize. What do we do with these social determinants of health? What are we supposed to do with them, right? It's been a real challenge for us, and people are figuring it out. What I'd like to present today is that the health plans, the state Medicaid programs, the delivery system, if we want to truly envision and really realize, true oral health equity, then we have to pay attention to those social risk factors, right? We have to. And how can we pay attention? How can we know what Johnny Smith's social ills are if we don't ask? Okay, so we have to actually go out and ask our members, our Medicaid members, when they sign up, when they become eligible and sign on. That should be one of the first questions that goes out, questionnaires that goes out is, what are your oral health issues? What are your medical issues? But also, what social issues do you have? What barriers do you experience? Is it childcare? Is it food assistance? Okay. Is there housing insecurities? Do you have trouble with transportation? We are not suggesting that dental offices address these themselves. We are suggesting in this conversation that at the health plan, at the system level, that information is collected from the members, okay? And that through a coordinated effort, those items are actually addressed, and that those individuals are then subsequently linked to social service agencies. Now, here's where I envision the most beautiful way in which Medicaid agencies of today, of 2022, and public health agencies, including oral health programs of 2022, can really move closer together and work closer together. And that is that the oral health programs fall under the umbrella in most states of the public health programs, right? Where a lot of these social service programs lie, and or funding or connections to them are they're all there. The delivery system, the Medicaid program, sits way over here, right? And traditionally has done nothing with those programs, nothing really. Okay, so now if you have a Medicaid program that's contracting with a managed care organization that is surveying members when they first enroll in the program and identify that food insecurities exist, or housing insecurities exist, or transportation barriers exist, then that health plan can subsequently deliver, and link to those social service agencies. And I'm panicking all of a sudden because I see my battery's going and I don't know what happened there. So sorry about that. If you saw my face get crazy there for a second. So this again is where social service agencies that fall into public health programs, where the offices of oral health lie, can link more closely with Medicaid and managed care organizations to really embrace and operationalize what we've come to know and understand about how addressing the social determinants of health can really help people get in and access those dental services. So a couple more last slides here, and that is, if we're going to address equity, we have to, again, address, I talked about this a little bit before, the dental workforce, okay, and the network. And again, traditionally, when we talked about network adequacy from a health plan or a Medicaid perspective, we looked at the number of providers in the program. That was it. If there were X percentage of providers, that was considered adequate. Or if there was X percentage of specialists, dental specialists I'm referring to, that was considered adequate. Or if there was a fairly decent geographic distribution, that was considered adequate. Now, we propose the dental workforce needs to be representative. And Dr. Grover showed some beautiful slides of how that data, how that the dental workforce is changing and the demographics are changing. I'd love to see those same exact metrics that Dr. Grover presented on the national basis used by every Medicaid, managed care, and dental plan program in the country. And so that to really know what your population looks like, okay, by collecting that race, ethnicity, gender information from the population, and then mirroring that, okay, in your dental workforce, in your dental network. And you can't mirror it if you don't know what it is. So that's really, really critical. So if we want to ensure equity and we want to ensure an equitable workforce, an equitable provider network, and an equitable access to care, we have to attack this from both sides. And then just these last couple of slides, this is the new model. This is what it would look like. It's either the health plan, either Medicaid or Medicare, or the health plan actually manages the benefit, right? They work with employers to design the benefit. If it's a government program, a Medicaid program, the benefits are developed internal. They're managed with managed care organizations, if you will. But the health plan also embraces a case management type of service, okay, which then connects dental providers and PCPs and other medical providers to the patient. So the patient isn't left there, all out there, all on their own, trying to figure it out for themselves. They're actually able to work and coordinate care, okay? And through those case management services, that health plan, that Medicaid, that MCO, okay, again, is connected to the social services, and again, back to the patient, so that those services are actually received. In order to do all of this, at the end of the day, right, we need money. We need good financing. We need to be able to ensure that the financing is sufficient to be able to do that. Right now, you saw in one of the earliest slides that the increase in Medicaid enrollment is up by 28% in just the last 2 years. So we can't keep up with this using the same model, which is why we need to shift to a value-based care model, which doesn't look at the number of services or reimburse providers for the number of services that are delivered. It reimburses for the type of services that are delivered, like, for instance, preventive services. It reimburses and it incentivizes the providers, okay, to deliver preventive services to keep the population heavier, to incentivize providers to not treat patients in the operating room, if at all possible, right? Because OR costs are so astronomical. So as we move forward, the triple aim, we heard that expression, 10, 12 years ago. It really and truly has not gone away, because at the end of the day, what we're really talking about is better care, better access to care through a variety of ways that all of us today on this call, in this meeting, have shared, but to do it and to be able to measure those health outcomes and to do it at a lower cost. So with that, I'm gonna pass it back. Oops, I've got to go back to this. Sorry about that. So Dr. Thornton Evans?
Yes, thank you so much, Ms. Foley, for a very comprehensive presentation, and really to all of the presenters today, including Rear Admiral Ricks, as well as Dr. Grover. We really appreciate the fact that you all work so hard to really show us how we can improve that access to achieve oral health equity, which is one of the overarching goals for Healthy People 2030. Before we get into a quick Q&A, I would be remiss if I did not acknowledge, with this being the 5th iteration of Healthy People, some really true leaders that are still actively working in the area of oral health. Dr. Alice Horowitz, who was the lead from NIDCR and has done a great deal of work, not only in federal government, but also in the academic setting, and definitely wanted to acknowledge her as really a pioneer in the initiative with respect to oral health as a Healthy People topic area. And then also Dr. Stuart Lockwood, who was my mentor at CDC when I first joined government. And he too was the lead from CDC. And it's a little ironic to be stepping into his shoes with respect to serving as a lead from CDC. And then also Dr. Candace Jones, who was a representative for Healthy People and its beginnings, as well as Dr. Patrick Blayhut. Later on from IHS, Dr. Chris Halliday helped to promote the monitoring of the Healthy People objectives, and Captain Renee Joskow, who's served as the HRSA representative and now just recently replaced with Dr. Adam Barefoot. Next slide, please. And we talked about today about the increase of the proportion of children and adolescents, as well as adults who use the oral health care system. And I know all of the presenters did a great job teasing out those aspects that are important for us to achieve health equity. And so these are just some of the strategies that, in terms of moving forward to success. But before I read those, just wanted to let everyone know, as Rear Admiral Ricks mentioned, one of the primary reasons for having this webinar were really to kind of fulfill the overarching goal of Healthy People, which is to engage leadership, key constituents, and the public health across multiple sections to take action and design policies that improve the health and well-being of all. So this is a critical overarching goal of the Healthy People initiative. And so we need to figure out how, and we really rely on all of you in the field to really help us to look at how we can improve access to care, especially to minority populations, those in rural America, using an integrated model approach, which both Dr. Grover and Ms. Foley spoke about, to also promote oral health delivery models that have been shown to improve access to care, and to work collaboratively to improve oral health literacy. Next slide, please. And before we get into the Q&A, just wanted to bring to attention for everyone, as a part of this Healthy People 2030 Oral Health Promotion Series, our next topic will focus on oral health literacy, which is also an overarching goal with respect to Healthy People, which is eliminating health disparities, achieve health equity, and attain health literacy to improve the health and well-being of all. And this will take place on October 19th, 2022. So look out for further information. The first question I would like to pose is to Ms. Foley. And that question is related to how state oral health programs can work more collaboratively with state Medicaid programs and MCOs to support the successful achievement of Healthy People 2030 oral health objectives, in particular, the leading health indicator, which focuses on dental utilization. Ms. Foley?
Thank you, Dr. Thornton Evans. One of the last things I mentioned in my presentation was the way in which public health programs can now engage with Medicaid programs and vice versa. We understand that the social determinants of health are real, and that social ills exist among many people, and they're not just limited to income, right? And so we need to either public health programs can help Medicaid programs by surveying members, or they can help by linking to some of these social service agencies and social services that become identified by members. I can tell you that in Iowa, MSDR is working with the Medicaid agency and the state oral health program, along with the Medicaid vendors in the state, to develop a survey where every time a new member signs up for Medicaid, they get sent this survey. And from this survey, if they identify that, food insecurities exist, then they are immediately rerouted over to either the oral health program or to a social service agency that can begin to address it. So I guess it's upping the ante, if you will, of really trying to address these social ills and not just talking about it anymore. Thank you.
Thanks, Ms. Foley. And the next question for Dr. Grover, what would be some thoughts about the role of dental education programs and improving access to care?
Well, thank you, Dr. Thornton Evans. Utilizing educational programs, it can be a critical part of expanding access to care. And I actually had that point offered to me by a director of a dental hygiene program that approached me at a presentation at a large group meeting. And she said, could you please remind patients that dental training programs are sites of care? We also see a trend over the past several years, and I experienced this in my health center as well, where dental students are actually spending part of their clinical years experience out in a community health center, out in a community clinic. They're learning some very valuable skills there. They are becoming better acquainted, and they are recognizing those social determinants because they are not in the silo of the dental school, but they're out there making an impact. And that will continue on after they graduate. That's what we predict.
Thank you, Dr. Grover. And for all of the panelists that presented today, what kind of system integration is needed to advance oral health equity for at-risk Americans?
Well, I'll start by saying I definitely think data is the answer to a lot of it. And if we want to truly integrate, for over a decade now, dental schools and medical schools have really, really stepped up, and there's been a lot of work to integrate healthcare and for our next generation of providers. But we haven't done that at the systems level, and we have to do it at a systems level. And right now, because coding is how we monitor services and monitor receipt of services, then we have to make sure that our coding systems are up to date. We can also use artificial intelligence, which is new technology, really advanced technology that I think is now available to be able to ensure that at the systems level, that integration is taking place. And so thank you.
Mm-hmm.
So I'll offer a thought as well. The fact that some Medicaid programs in states have implemented some reforms, they have done so because of advocacy efforts. And so it is an entire community that needs to realize that oral health is important, not just the oral health program planners and those that are involved directly with oral health education programs, but it is those systems in place, as Mary so beautifully pointed out. In particular, why should funding within a Medicaid program be so much lower for oral health services than it is for medical services? That increased recognition and that funding equity, if you will, that oral health equity consideration should be front in the minds of the policymakers, and it's an election year. There's no better time to make that point.
Yes, thank you, Dr. Grover. And I would like to hear from Rear Admiral Ricks. I'm going to put him on the spot. Today is pretty much his last official day as the Chief Dental Officer for the U.S. Public Health Service. And I just want to let everyone know that he's been an exceptional role model and leader as far as I'm concerned, and with really trying to promote a spirit of collaboration across all entities even outside of federal service. And he's meant a lot to me just in terms of his support, his unrelenting promotion of healthy people. I don't know how he does everything that he does, but I know that has been enjoying his leave before actually going into retirement. So Rear Admiral Ricks, can you close us out with respect to this first webinar?
Yes, thank you, Dr. Thornton Evans. Thank you, Ms. Foley and Dr. Grover. And thanks for everyone that participated today. You know, first of all, let me thank Dr. Thornton Evans. She thanked all these people that have led Healthy People for the past couple of decades. And Dr. Thornton Evans, at least for Healthy People 2020 and 2030, has been at times the torchbearer for Healthy People from an oral health perspective. So thank you for your continued leadership and guidance on Healthy People. And of course, thanks to the ADA and MSDA and all the other organizations that have agreed so far to participate in sponsoring future webinars. Healthy People, when we started talking, Dr. Thornton Evans and I, about this series, we said, how can we make it real? Because it's just a set of national objectives, and to the everyday oral health provider, you know, you don't really pay attention to these national measures all that much. How can we make it practical for you? And that's why we have teamed up with different organizations. And as we go through this webinar series, and this is going to be going on hopefully for the next 8 years until we get to 2030. We're going to find examples around the country from community health centers, from private practitioners, from national programs as well, on how they have the best practices that they have developed to specifically address those 11 oral health measures. And there's been some really good conversation in the chat as well, and I encourage you to continue those conversations and do what you can to help promote these Healthy People objectives. So it has been, Dr. Thornton Evans said this may be my last day. No, this is my last day. There's no maybe. At 12 o'clock midnight, I will probably be awake. It'll be bigger to me than the millennial New Year's Eve. And I will be retiring at midnight. So I want to thank all of you who have supported me, supported the Public Health Service, supported Healthy People, and supported all of our agencies within the HHS over the last, at least the last 4 years, but many of you much longer than that. So with that, I look forward to seeing you all join. Hopefully we'll have more people next time. On October 19th for our next webinar on oral health literacy. And with that, I'll turn it back over to you, Dr. Thornton Evans, for the last word.
Thank you, Rear Admiral Ricks. And he also told me that this is the last day I can call him Rear Admiral. So we'll see that. But I want to just thank everyone for attending. We really appreciate all your support, and we definitely do count on all of you at the community and grassroots level to really help to advance and increase the visibility of oral health in all aspects. And I cannot thank enough Ms. Mary Foley and Dr. Grover for all of their support and being willing to support this effort. And there will be continuing dental education certificates provided. And I really thank ADA and under the leadership of Dr. Grover for being able to put that into place. So many thanks to them. And please feel free to reach out if you have any questions or concerns, or you have any additional questions that we weren't able to address today. But thank you so much. And I agree with the chat. Rear Admiral Ricks is a superhero for sure, because I don't know how he did 4 years of working what seemed like 24 hours in a day. I don't know how he did it. So many thanks to him for his leadership. And thank you all, and have a great rest of the day, and be safe.
Okay, thank you.